Good morning, everybody. Thank you all for your time today. As I'm sure many of you already know, we set these case study presentations up in the summer of last year as a way to offer a chance for clinicians to discuss the value of using our tests in practice and the therapeutic interventions that can be built from some of Genova's flagship tests, such as the GI Effects and the NutriVal. So today's presentation will be delivered by Dr. Elizabeth Corcoran, who is both a psychiatrist and a practitioner of functional medicine. Dr. Corcoran is also running the only UK charity focused on medical research helping people with Down syndrome. Liz will be presenting a case with a patient presenting with Down syndrome and IBS symptoms on the GI Effects Comprehensive Stool Profile and the Metabolomics plot, along with the therapeutic methods employed by Dr. Corcoran and the follow-up results after treatment. So before we get started, I just wanted to share a couple of logistical bits of info. So there will be time for questions at the end, so please write your question in the question tab on the GoToWebinar control panel as and when they come up for you along the webinar. And in addition, you will see that there is a tab that's labeled as handouts at the bottom of the control panel, where we have uploaded our stool test and NutriVal support guide, as well as the fee schedule. So please do use those support guides to help inform you as to how to interpret the tests and the information on each of the biomarkers that we test on those tests. Lastly, this webinar is recorded, and so the link will be sent out to you later on today, so watch out for that. So without further ado, I'll let Dr. Corcoran take over.
Okay, thank you so much. And I'm sorry that I haven't got my camera on. The technology is fighting us today. We did give it a good try, didn't we? So you don't need to see me. We can talk and you can use your brains, and we can think together about this young patient. But before I started, I just kind of wanted to lay the scene a little bit, because obviously, you know, you come along, whatever something in the title interested you, and maybe you know someone with Down syndrome, or you have been approached by possible clients with Down syndrome and you'd like to take them on. So I'm kind of maybe hoping that we'll get some more courageous practitioners out there that think I can actually help these people and help people that do have genetic conditions actually in really practical ways. But I'll just start by declaring my conflicts of interest. As she said, I am a chair of a research charity, which I'm a volunteer, and I also do associated advocacy, human rights work around that, and also was involved in the recent bill that passed, the Down Syndrome Act, which we were very excited about in our community, which should improve the healthcare and education of people with Down syndrome. And the reason why I'm here, I'm also a doctor in private practice. So why am I here? Why am I doing this stuff? I've got all these different hats that I wear. And the reason kind of a lot of it is centered around this young man, my brother David. So as many people with someone with special needs in their family do, I went into a caring profession, and in particular specialized in psychiatry. But as is the story, I was disillusioned by the treatment that I was able to offer. There was too long waits for therapy. It was just a prescription pad. I was always interested in nutrition, and it allowed me to combine my loves of caring for the root cause and actually getting people well. So this is who I am. So the aims of this talk is we're going to think about a case of someone with Down syndrome and the testing and how the testing played a role in guiding the patient's recovery and getting them well. But, you know, obviously I have to put that disclaimer. You're not going to be a Down syndrome expert at the end of this, of course, but hopefully we'll feel more comfortable about taking patients with special needs, such as my brother, into your clinic caseload. So let's start by thinking about Elizabeth. Elizabeth's 8 years old, and as I've said, she has Down syndrome. And we're going to think about what Down syndrome is in a minute. But she has chronic bowel issues, fatigue that really affects her. And this was what Mum put on my intake form. With a magic wand, she would love her daughter to have more energy, better concentration, and improved skin and nails. Mum didn't even think I could touch that constipation stuff. Like, she was just like, that's just the way she is, and it will always be the case. So it was nice to be able to actually say, no, we're going to work on all of it. We're going to think about all of the things that affect Beth. So let's remind ourselves what Down syndrome is. So Down syndrome is an extra copy of chromosome 21, and you'll see it there on the bottom row, this little extra cheeky chromosome there that snuck across early on in development, sometimes after fertilization and after a certain number of cell divisions. You can have some of the cells that have chromosome 21 extra, some that don't, so that's called mosaic Down syndrome. And there's 300 extra genes on that little nub of a chromosome, okay? And these aren't like 300 disease genes. They're 300 just sort of normal genes that are important for all sorts of functioning. And we'll talk about maybe whether that was reflective in some of her testing. But a lot of those genes are involved in methylation and oxidative stress. So any impairment there is going to be important to some of the pathways we look at on our organic acid testing. And then all of those things that then are important for creation of compounds such as glutathione, okay? So when an initial kind of paperwork was done and we sat down and started looking through and talking about Elizabeth's history, her MSQ came back at 43, which would kind of consider her mild toxicity. She had a complex early birth history, which is quite common in people with Down syndrome. For her, she had something called duodenal atresia, and I put a picture of it there. And it can go anything from a disconnection in the duodenum to a sort of a tightening or slight tightening. So that was kind of what she had, the type that was connected, but there was a tightening. So that needed early surgical treatment. And she had an NG tube for the first 6 months because of poor feeding. She also had some heart issues, so an atrioventricular septal defect, which required a procedure to close that hole in her heart. Now, early on in our first year, she had various admissions for pneumonia, bronchiolitis, croup, just in and out, in and out. Mom felt like constantly there. And Mom's a nurse, and she began to sort of put 2 and 2 together that maybe there's something going on with aspiration. She isn't swallowing properly. So Mom requested that she be put on a thickener, and things began to improve. But unfortunately, that was when things began to deteriorate in her bowel history. So around 2 years old, Mom began to notice she was distressed whenever she came to try and do potty training sitting on the loo, and would need to be in the bath, right? Would need that warm water, and that would unfortunately be the only time when she would open her bowels, much to Mom's dismay. Lactulose and senna didn't touch the situation, right? So these are 2 of the sort of first line conventional treatments for bowel habits. And the stool itself was abnormal size and shape and length. It just didn't seem like what you would expect. By 3, bowels actually culminated in an episode where they weren't open for 6 days, and Mom then had to go to A&E. And that was when these sort of the commencement of Movicol was given. And then they said that time, they gave 8 sachets of Movicol to get things moving. And then once the stool was liquid, they began to pull back a bit. And Mom said they eventually settled on 2 sachets of Movicol twice a day. By the time she's about 4, Mom sort of started to hear about this kind of fad, this gluten-free thing. So she said, okay, let me try, just see. I probably won't do anything. But it actually seemed to make her sleep better, and she was able to taper back the Movicol a bit. Now, why does this matter? Why does it matter that like a 4-year-old with special needs can't go to the toilet? And Mom's quote was actually really powerful. Our whole life was centered around her going to the loo. It was distressing for us and for her, okay? And a child that can't concentrate, can't go to the toilet in a reliable and sort of regular manner, can't learn and can't engage in activities. And she was just really tired. She needed naps after school and actually was falling asleep in class. Let's remind ourselves, I've mentioned this word Movicol, and probably most people either know a family member or someone, or they have patients on this. Movicol is a type of PEG laxative, polyethylene glycol laxative. And why does it matter? Why do we care as sort of functional natural practitioners if our patient's on it? Well, because we have some evidence that it does affect the microbiome, okay? So we see from this middle part of the diagram here, thick and healthy mucus to a disrupted mucus, okay? That polyethylene glycol in this mouse study affected certain bacterial families, and actually they were then missing. You could replace them, you could reseed them, but most people don't think like that. They just get stuck on those laxatives for long periods of time. So it does cause changes in that gut microbiota immune system conversation. So it isn't nothing, it isn't innocuous. We need to be aware that it does cause changes. So what did Mum think? What could I kind of get her to do first step out the gate? Well, Mum was like, okay, then what's the best diet? I dabbled in gluten-free, but can I do more? Can the constipation be improved, or is this just her lot in life? And what about that tiredness? And I am in the back of my head, I'm thinking, is this child having sleep apnea? You know, because that's very common in Down syndrome. Has it been tested? It's commonly missed in clients with Down syndrome because we know that apnea can affect gut motility, right? Has she had her recent thyroid testing? Also, hypothyroidism common in Down syndrome. Has that been checked recently? And I really want to see what's going on in her stool. Okay, I want to understand like this early history and this Movicol, has it affected the gut microbiome and her digestive functions? And also then knock on, has it allowed her to get into a state where she's low in some nutrients? And that would be the organic acid testing I'd want to see. And I want to get going on the diet. I'm really keen, but Mom's not so keen. So this is one of those clients who she hadn't heard of stool testing. She hadn't heard of organic acid, you know, so I needed to get her to a point where she understood the value in sort of larger scale diet changes beyond just a bit of gluten-free bread. So we decided we would do very, very minimal interventions, and we would see what the testing showed. So let's go straight to talking about the GI Effects stool test and think a bit about her results. So this is what we got back, and you know, I was pleased we actually got some real solid information back that we were able to then think about. And this is your front page when you get your testing. Hopefully some of you guys have done testing before and you're used to that familiar front page that you get back from Genova. And it was really helpful to see actually, and reassuring that, okay, despite the fact she's had some surgery around her duodenum, okay, there's some digestion issue, but it's not as bad as it could be. But I'm seeing some clear situations that gut is not happy, and there's immune reactivity going on, and we're going to show in a little bit more details. Now, one of the things that I think is quite helpful with the stool testing, the first few pages, is that Genova's done this. Obviously, they've got more than one country they work on, and it's important when you talk with your patients, it isn't just sick people who have done this test. To begin with, they did this test with lots and lots of people who were quote unquote healthy, right? So people who didn't have complaints, digestive or otherwise, because we needed to understand like what is normal? What does a normal gut bacteria look like in someone who doesn't have all sorts of health issues? And then when, you know, you and I who have clients who have issues, we can see, okay, where does our patient fall on that continuum? You know, are they standing in the group of healthy people in terms of how their microbiome looks, or are they grouped with people who also have symptoms and difficulties? And when you get someone who's had a lot of antibiotics, you actually don't always get them having a deficiency of the microbiome. You know, people's guts bounce back from antibiotic exposure. And you can see in this situation, she's got a sort of slight overgrowth. So she's a bit overgrown in her gut. And you also are able to sort of use algorithms to place them on a sort of continuum in terms of their inflammation associated dysbiosis as well. So in Elizabeth, we see she's kind of coming low, and the methane score, she's coming a bit high. And the methane scores in a cohort of people that have done the breath test and the stool testing, okay? It's looking at those two together and actually saying, Do you need to be really sort of suspicious that your patient's going to need breath testing as well to look at the composition and the gas production of the bacteria in that gut as well? And I think with these first few pages, when you're looking at where your patient falls and all these big datas, you have to think about the patient that you're seeing as well. So you take what Genova's giving you in terms of the algorithms and where the patient is with that data, and you put it in the context of the patient in front of you, because things like immunosuppression and other things are going to affect those plots as well. So it's helpful, gives you a feel, it starts to warm you up for what you're going to see on the next couple pages. But for Elizabeth, okay, I'm seeing a pattern of dysbiosis, and I'm seeing a pattern where she is standing in that big cohort of all the people who've done the stool test with Genova. She's standing with the people who are kind of poorly. She's not standing with the fit, healthy folks who don't have any health problems. She's standing with the people who have health complaints. So we're guessing that gut microbiome picture I'm about to see is contributing to those symptoms, right? We're thinking that there's some association. And she's in zone 2, and those people in zone 2, they seem to be higher risks and higher rates of opportunistic infections. So we're going to see that as well in a minute. So use your guide that Genova's produced to help you navigate these pages, and also book a chat after you've got your results, because the team are really good at getting people comfortable with using the tests. So again, we see she's standing with the people who are only 5% of people in that yellow zone were healthy, right? So only 5% of them didn't have issues and had gut microbiomes similar to her. So let's look at her actual results. Let's start by looking at digestion, okay? And we can see that, okay, first of all, her pancreatic function, her elastase, and that's an enzyme that kind of comes out the other side, not digested, not broken down. And it's our marker of sort of gut function. And that's a useful one where our colleagues in the NHS, they run elastase tests. If you see low ones, you need to investigate that and hand that back to the GP to look into pancreatic dysfunction. But, we like for it to be over 500, nice kind of dynamic, healthy pancreas pumping out enzymes. We can see she's a little bit saggy, 8 years old, maybe, she's a bit too young to be giving up function. So, I'm noting that. It's in the group, but I'm noting that in my head. And, when looking at protein, okay, I'm happy that there's she's within the normal range there for products of protein breakdown. Fecal fats is another complicated area, which you can't look at any one of those and say that is, I need to be giving some fat enzymes straight away. Look at that, it's all wrong. You need to look at the guide, you need to understand of each of the types of fats, which ones represent malabsorption, which ones represent maldigestion, okay? So you need to think about that. And there's some indicators there that her cholesterol is a bit low in her stool, okay? So unpack that with each of your clients. If we move on to inflammation and immunology, we're looking at the marker for inflammatory bowel disease, which thankfully is normal for her. But obviously, we're getting to see a really strong reaction on our fecal secretory IgA, okay? And that's that non-specific immunoglobulin that's secreted at that lining of our gut, okay? And it's a bit like a pawn. It's the first soldier in the line of defense, okay, against bacteria, parasites, but also food reactions, okay? So we don't know why and which one it is, and if it's more than one, but I'm aware something's happening and the immune system is reacting at that gut barrier. Okay, let's go on to C. Her microbiome. This is their economy. This is are they producing things? Are they working hard? And we can kind of take this portion with a little bit of a sort of grain of salt if you're going to make dietary changes, because this is going to shift as soon as you start making your dietary changes, because you're going to be getting different bacteria families producing different levels of these compounds. But it's important to explain to your patients, why does it matter? Why are these compounds important? Because we know from research, butyrate's cancer protective, and these compounds feed our gut lining cells. Okay, so we want our gut bacteria to be healthy, in their balance, but also to be productive, right? For their economy to be active and high. And then our beta-glucuronidase, which is an enzyme used to digest carbohydrates, okay? And having it low is difficult to interpret, but we generally want more beta-glucuronidase, and it's reflective of some of the imbalance there with E. coli and anaerobes, okay? So as we change our diet, we're hoping to see the glucuronidase come back up into that normal range. So if we just take, I'm not going to spend a whole lot of time breaking down the different families, okay? But again, when you look at these pages, this is the DNA fingerprint. So these guys are present in the PCR result. So that means that they were present in that leftover DNA in the stool. And we can see that some of the groups are very high. Some of the groups have been very overgrown. Others are trending lower, okay? So some of them have been damaged by the antibiotic use or the Movicol use. This is our second page where we look at the further down the same page. Again, see some of the groups very low or not present at all. Some of the ones I don't want to be present aren't, so that's good. I'm relieved. But overall, you know, say something of protective bacteria like Akkermansia, low, right? So we want to be giving us lots of sort of purple fruit and veg to try and increase those protective Akkermansia, because having the good bacteria in good numbers push away and improve the sort of balance towards good bacteria. Okay, so we get to our parasitology fingerprint, our PCR, and we can see, right, yes, opportunistic bacteria have taken hold in Elizabeth's gut, and we've got Dentamoeba who has been detected. And here's a lovely couple of Dentamoeba smiling for the camera for us. And I'm going to run through the metabolomics test as well, and we're going to talk about, we ran them both together, but I'm going to talk about the approach I took after we go through that. So the metabolomics test is a urinary organic acid test that patients can do at home, okay? And it looks at cellular functioning, okay, by looking at sort of where are the blocks in those cycles, and we're going to see an overgrowth. Now in Down syndrome, I mentioned there's extra 3 copies of some of the genes, okay? But we understand from research, it doesn't mean there's 150% of some proteins, okay? The body is clever and it switches off some of those extra copies. So it's not like you can always assume what someone with Down syndrome will have on their metabolomics test, okay? This is why this test is so useful in people with Down syndrome, because it allows us to see that personalized approach, okay? Now, straight away, when I ran her test, I could see, again, big need across the front panel and in particular, oxidative stress being really important. And in particular for Elizabeth, also toxic exposure with some of those compounds being elevated in her urine, likely due to, you know, poor detoxification blocks in her various cycles of detox, okay? Now, for those of you who are just starting out, this is a real comfort page where you feel, okay, I feel familiar. I like this page because I can use it with my patients and really help them to see in a real clear manner where the areas of need are in terms of, you know, their biochemical cycles have got blocks, and the reason they've got blocks has highlighted these certain compounds of need, okay, certain B vitamins and minerals as well. Okay, and when you talk to your patients, I generally talk about the use of computer algorithms down at Genova. They're very clever, that once they analyze all the compounds in the urine, can help you to produce this report to guide your supplementation. Okay, and Mum was really, you know, thankful that we actually had run this test, because it allowed us to clearly see the level of need around antioxidants for her. Now, she's a young lady that was eating a good diet. Mum cooked a lot of meals from scratch, but she needed more, okay? The level of demand was high. Now, as you get more comfortable with your metabolic cycles, okay? You won't begin to feel sick when you look at this page. You'll begin to kind of feel more comfortable going through it and actually talking your patients through it, especially the patients who are really into this science. Now, at the top, you're talking about all the various inputs that we have into our bodies, fats, carbs, and proteins. And you're talking about the ways in which each one produces energy and how they're different pathways that they're made and where the blocks were. And whether these are, blocks as in the accumulation. So that sink analogy, it's becoming full of malic acid. It can't move to the next stage. And the reason is likely due to being low in cofactors, right? So things that each enzyme is needing to do the next step, okay? Now, the other thing to bear in mind is that, yes, you can be low in these cofactors, but bear in mind as well, these things can inhibit these steps. So you need to think about that, two sides of that same coin. The enzymes need cofactors, but also what might be inhibiting my patient's metabolic cycles. And then we go down to looking, this is just a representation of the cell membrane on the mitochondria, right? And this is where our energy is made. This is electron transport chain. And what the way energy is made and the way we do protecting ourselves from compounds, invaders that come in, immune system. So there's a lot of little mini explosions that happen in our body, and that the cell membrane needs to be able to mop up those and clean them, put out the fires. And that's where the antioxidants are vitally important to repairing that cell membrane. And we know that when that process is out of whack, we see more lipids damaged. So we see the increase in lipid peroxidases, and we also see DNA damage, right? So that's what this marker is talking about. So when we get that back, we know that actually the explosions are not being cleaned up, not being repaired. The electron transport chains making these mini explosions to create our energy as well, and we're seeing going towards a net damage instead of that, holding that nice calm balance between creation and repair of free radicals, okay? So again, I've just gone into that a little bit more detail, but seeing the representation on the picture that Genova gives us, but also on the slider as well, okay? And why does this matter in Down syndrome? And here's just a publication that rocked the Down syndrome world in 1995 over at Yale, I think it was. They looked at fetal Down syndrome cells and age-matched normal brain's non-Down syndrome cells in labs, in cultures, and they saw there was increased apoptosis, cell death, and generation of free radical species in Down syndrome neurons, okay? So that this paper by Yanker is so important in our world because we understand how critical uncontrolled reactive oxygen species, so unmopped up explosions, are in Down syndrome brains, right? So we need to get this under control, okay? And it's believed to be, this is why we see early kind of increased aging in Down syndrome brains and cells, and increased rates of predispositions toward Alzheimer's in adults and early Alzheimer's coming on, okay? So I want to get that under control. On the pages following that graphic representation, you get the markers so that you can look at them. You get actually some markers for digestion as well. So if patient can't run both tests, you kind of get a bit of a look on both sides. So you can actually see, because some of those compounds that signify maldigestion, actually they show up in the urine. So things that the bacteria and dysbiotic bacteria produce actually don't come out in the stool. They get ended up absorbed, pulled into the body, and excreted in the urine. So that's why we know from this test that we can get a bit of a feel for what's going on in that from this urine test as well. So, for example, the high PAA in the urine, that can suggest incomplete digestion and absorption of phenylalanine in the intestine, okay? And that allows colonic bacteria to convert it to PAA, okay? And so we know that it can reflect an overgrowth of that bacteria. That's because that's showed up in the urine and can be linked to several bacterial strains such as Bacteroidetes and Clostridium. Okay, so it gives us a kind of window into the gut as well through this testing. And we get other markers from the different parts, the different markers for different B vitamins, and some markers for serotonin and some other neurotransmitters, and allows us to kind of have a bit of a view of what might be happening in terms of those cycles as well. Okay, so I want to jump on to talk about what I actually did, because I think a lot of you guys are probably curious about that. So the treatment plan. So by this point, Mom's sort of nervousness about, going in 2 feet into diet change has kind of gone. Mom's keen and she's ready to kind of change some things. And I went ahead and bit the bullet and talked to Mom about beginning the elimination diet. Okay, the reason why was that secretory IgA was high, and I don't know why that's high, but I always assume that there's going to be some damage that's happened with that gut barrier function and the food, the conversation there between the immune system and the food. Because the food's being visible to the immune system, it's likely one or more foods has become an issue, and there's antibodies reacting against foods. The safest and easiest, clearest way is just to clear house, right? Remove those foods and begin to do some of the things on that lovely wheel from IFM, reduce inflammation and start improving identification of food triggers, and obviously in your adult patients, promoting body awareness to food and that kind of stuff as well is really important. I brought in some as simple as possible plan. Okay, Mom is not a kind of, as we call it, granola head. She's not into all of this stuff. She needed a really simple plan, or she was just not going to keep up with it. Okay, so I went in there with a compound we know is associated with improving gut function. It's associated with improving constipation. So I added L-glutamine. It can be dissolved and put into smoothies. So everything needed to be liquid. Okay, so I added in something to reduce the dentamoeba. Okay, I went for a blend, liquid blend product, something called Para 3, which is very easy to dose based upon weight. So I could make sure she was getting a safe dose for her age. And it's a blend, as I said, a blend of antimicrobial herbs or antiparasitic herbs. And added in Saccharomyces B, because there's also evidence that that can help eradicate or reduce the numbers of dentamoeba. I wanted to get in there with some antioxidant and protective compounds, but I managed to get omega-3 in there to start improving so many things. As you guys know, omega-3 is so important for so many different aspects, but improving her lipids, improving her immune system as well. And we were going to then move on to a next stage where we talk about treating what I found on the metabolomics. But I had to let's get this first stage done where we're looking at improving the gut, okay? And some feedback I got from Mom, which was wonderful. And actually, she's a type of mom, she put this on Facebook, so she's spreading the word. A month or so ago, we started her and all of us, cry emoji, on the elimination diet. No gluten, dairy, eggs, refined sugar, and a few other ones too. Dreaded making the change, but it was clear she wasn't tolerating some foods and was lethargic, grumpy, and found concentrating hard. Today, I got this report from her OT, occupational therapist. It shows the importance of good gut health and how it affects all areas of life. It makes all the sacrifices, which we've gotten very used to quickly, well worth it. So Mom became a bit of a preaching of the gospel here. So this is from her occupational therapist, the little girls at school. Wow, Elizabeth was on great form today, so focused and engaged. All staff felt that the last 2 weeks have been so positive, with Elizabeth working more and more in the class and not needing so much time out, coping well and doing her work in class at the table, and sometimes 2 other children with the rest of the class to get on with their work too for the subjects that require differentiation. So this is a child who is in mainstream setting, so was often, falling asleep at her desk or requiring one-to-one support. So this is incredibly great feedback from the occupational therapist. So what do we see in that early stages? We saw actually one of one of the most encouraging patients I've ever had. Is like her growth chart went from plateauing to almost a vertical a vertical climb, which was wonderful. And you know, she was nervous to attend brownies. She was nervous to sort of do new things. She became more bold and decreased anxiety. And constipation was improving. Mum was able to get Movicol down to half a sachet a day, and then actually was ready to get completely off of it. Okay. And from that point, we then, I left Mum to take Movicol, and Mum actually joined a clinical trial that was running and began to add in the probiotics, Simprove, who funded a large study in constipation and Down syndrome. And that was the final sort of help she needed to stop the Movicol. Her stools became normal. So we were very excited by that. And then we were able to move to a phase 2 where we were treating what I found on the metabolomics. So we stopped our antimicrobial and we moved on to a powdered multivitamin preparation, and we increased her omega-3 further. So Mum was able to keep up with that, and she was doing well. But then time passes, we get a bit slack, and I meet up with Mum, and she goes, "Oh, didn't I tell you she's been on thyroxine and has hypothyroidism ever since 2019?" At which point I said, "No, we didn't know that, but okay, we'd take it on board." And I asked Mum to please, next time she's having her yearly thyroid check, would you guys mind also asking them to fill an additional tube and run the Thyroid Plus panel? Because as we know, the NHS thyroid testing is limited, and we often want to have a look at those antibodies. They don't always run them. We want to have a look at the reverse T3. So this is where we kind of left this case on stage 3. So these were the sky high results, and obviously jaw-droppingly, big reaction there going on, and active autoimmune disease going on in Elizabeth's thyroid. And for me, the next stage is actually we're circling back. We're looking at, well, what's happened? Okay, Mum opens up. Well, first it started with a little bit of butter here and there, and a lot of the foods which she identified as being trigger foods have made their way back into the diet. So we're kind of pulling up our stockings and getting things back again. But actually talking to Mum about how what goes on in that gut barrier, having its important kind of issues elsewhere in the body, and how important this is that we try to reduce the amount of damage that's done to her thyroid, because she's going to need that thyroid her whole life, and reducing the amount of medication she might need, hormone replacement through her life, is going to be so important. So at the moment, and I'm going to not dive into the treatment plan there with the thyroid, but so much being around the diet and a couple compounds that have shown promise, but trying to improve the thyroid autoimmune disease by getting the gut barrier function right again is going to be my next focus. But if we're happy, we'll go to questions now and give ourselves a bit of a time for conversation and questions. So thank you.
Thank you so much. That was so interesting. And yeah, we do have a few questions. One of which is talking about B12, and specifically the question is why B12 might come up low with the metabolomics. And I'm assuming what this person means is a high methylmalonic acid. So why B12 may come up low on the metabolomics and high on a blood test. I'm not sure whether that's a question that you can elucidate.
Yeah, very complicated question with the B12, and it's something which frequently comes up in my doctor's conversation, because it can be very confusing to get a high B12, and you end up actually saying, well, everything's fine. Look, you're high, so stop your supplements. And then the patient says, I'm not on supplements. in that situation, if you're getting a high B12 on your blood test and the patient's not on supplementation, you need to kind of look at what's going on inside the gut. Okay, so some gut bacteria can produce B12 and cause that to go high. But you also need to investigate whether or not there's something more serious going on, and whether there's any signs of cancer that might be present. So the patient would need to have further investigations with the GP. Now, if the GP doesn't, you may have to sort of highlight that to the GP, just remind them that they may like to refer the patient to a hematologist to investigate the full B12 and its precursors in more detail, because there can be reasons there why the patients come up as having a high B12 on the blood test. I hope that kind of gives you a bit of a taster, but the issues around B12 and its precursors are very complex, and that definitely is an area where if I was a nutritionist, even as myself doing this, I don't like to fly solo. I like to get the backup of the professionals in the NHS who can check for the more serious causes of elevated B12.
Thank you. That was great. Another question here. Someone would like to know the name of the antimicrobial brand that you used.
Okay, so it's called Para3. Para3.
Is that by Igenis by any chance?
Let me just look up where it is. Para. And I get it from Amrita, and I'm sure it's available elsewhere.
Yeah.
And the wheel is going round. Cellcore make it.
Okay,
yeah, Cellcore. I mean, Cellcore have a whole protocol that they say, use this level 1, 2, 3, and 4. That's why it's 3. But I'm comfortable to use it as a standalone product. But if you obviously chat to Cellcore about the way they use it, and
and how long did you use the Para3 for?
I generally go for the 4 to 6 weeks mark, and
okay.
I saw, you're dealing with a young patient, you're dealing with busy moms. I can remember seeing a teenager with Down syndrome who had seen another sort of functional practitioner, I think 2 or 3 years ago, and they sort of put on the supplements on, oh yeah, just this is what we were taking since we've seen her. And of course out came the biocidin. I'm like, oh, you've been on that? Like yeah, we've been taking. So that she had actually just continued that antimicrobial for like, I think 2 or 3 years. So just be super clear that patients understand, that this is an antimicrobial. So it's like a herbal antibiotic, use that language, because that's what people understand. And that, I make sure it's in nice bold writing, 4 to 6 weeks. Do not order a second bottle. Like, stop after that amount of time, and we'll revisit. You may need to put patient back on more, but you need to be the judge of that. Yeah.
Yeah, absolutely. And because this patient was a young girl, did you follow specific guidelines by the company itself, or did you sort of go by a small percentage of the full dose?
I used the company's guidelines, but I started on the lower end and built up. So with the Para3, they sort of give you a age and a weight range, which is quite helpful because some of our patients are underweight, and so you need to bear that in mind. Is your patient towards the sensitive end? Do you need to go extra slow? And it's better to have more caution than to just think, okay, top end, let's go for the top end of that age range. So and then build up slowly. And generally it's rare that you see reactions, but they do happen. So you have to bear that in mind. If you're seeing a change, could it be that you've gone too hard and too fast, and then just pull back a little bit?
Yeah,
Some,
no.
I will say is, yeah, sorry, I will say as well that some of people with learning disabilities, we talk about them having more sensitive brains to medications that can affect brains, and whether that's the same for guts. I haven't seen that reflective, but I definitely go sensitive, like slower on compounds that might be affecting the brain. So definitely go like half of the normal dose and just kind of build up and see. Same with like the elderly. You just go a little bit more cautiously and,
Mhm.
watch out for like reactions.
Yeah, and she was okay. She didn't have any significant reactions to that at all.
No, no. She did really well actually. And mom actually, she packaged it all as a smoothie after school. So it was all sort of, in the one dose there after school. And yeah, it was lovely to see that she
Mhm.
took it. The only problem is that she began to be able to taste it towards the end. So we were pleased that um, we had managed to get to the 6 weeks and see a benefit. But yeah, some of these little kids, as they get better and healthier, they can sometimes become a little bit more wise to what you're up to. So you kind of have to, change the plan, change the tact a little bit sometimes.
Yeah, yeah. Okay, we've got another question here. Someone's asking if you have seen older children and adults with Down syndrome, and if so, have you had or managed to find an easy way of obtaining a stool sample from them, or would you recommend working with the metabolomics to start with?
So I have seen adults as well. And I've never had an issue with getting a stool sample. The carers, the parents, the loved ones who brought them have always been really helpful. The Genova's got a good little video that talks people through the actual test. Now, that video is very helpful for carers. I wouldn't say it's pitched to someone with a learning disability, but that's fine as long as the carers understand, you know, what sort of things need to be stopped ahead of the test. And the tip that I sort of tell people is the cling film on the toilet. I'm sure you know this one. Lift up the lid of the toilet and then put like a sagging cling film underneath, and leaving space for urine to make its way out the front. And generally that works pretty well at catching the stool sample and allowing you to do a good collection for the sample. And I, you know, I I generally get people keen to do both. But if you're down to, which one, I would say run the stool test first, because that's that foundation for that building. The body's health is resting upon that gut function. And, it doesn't matter if, you discover XYZ deficiency, if you're not able to get that into the body, the replacements, because you've got like a real bad dysbiosis, you've got to get your chicks in a row, or whatever they say, ducks in a row. So I generally get the patient, then the carer or patient, to space out. So do the stool test first, and then we'll do that. And what I'm finding, for those of you guys that are in the UK, patients are given a budget for personal care, and a lot of them have a healthy amount available that they can use on their own healthcare. Some of them join a gym, some of them do other things, and actually there's a growing community of people, families, and adults with Down syndrome who want to use it on alternative integrative health approaches. So that's what we kind of talk about, that actually this is a really build this into your kind of yearly budget, that you're going to come and see someone like Dr. Liz, and she's going to help you think about, well, what do your supplements need to be targeted at this year? Because despite they've all got that extra chromosome, it's different. Your trisomy 20, your sort of chromosome 21 is different than mine. So the expression of Down syndrome would be different in every single person with Down syndrome. Yes, there's overlaps, and be aware of the increased rates of some conditions like Alzheimer's, but this isn't, they're all different. So you need to take a different approach for each one.
Yeah, that makes absolute sense. Just to add on the question that was asked, just so you know, the stool test doesn't need to be a consecutive, 3-day stool test. So day 1 and day 2 stool samples, they actually have a stability of a few weeks. It's just the day 3 that has a lower stability time. So, essentially, you don't need to collect stool every day for those 3 days. It can be more spread out if there is that pressure of, how am I going to collect the stool for this patient? So just so the person that asked that question, just to give you an insight into that.
Yeah.
So
and I would say as well, can I just go in, because I've had patients that they've ended up extremely unwell in hospital due to constipation. If someone's died, you won't be aware of this, but we've had someone in our community that actually died because of untreated constipation. It's just an utter scandal that happens in our community. So, not surprisingly, I've had a number of parents that have come to me very scared to touch the Movicol, very scared to do anything. And Genova has always been they can't say, that's fine, it won't affect results, but they've encouraged me, yes, in those situations, we have to be pragmatic. There's really poorly people out there who, can't stop their PPI, and you can get a lot of data out of a result, even when someone is on that. You can maybe ask them to, maybe do it after 12 hours, or there is room, and it is still worth doing testing, even with our patients who are really scared about letting go of the security that medication has given them for the bowel regularity, and to understand a little bit behind why there's so much fear there, because of this terrible thing that has happened within our community around constipation under treatment.
That's terrible.
Yeah.
I'll just add on to that with, having to continue taking something like Movicol to produce a stool. In terms of the markers that might be impacted, we don't know absolutely, we don't know for sure what exactly will be impacted, but normally we do see an impact with things like the short chain fatty acids, where the percentage of the short chain fatty acid and the total amount of short chain fatty acids may be impacted by using an osmotic laxative or another type of laxative. But in general, I would agree with Liz that it's better to get a stool test done, even if you have to stay on that kind of medication to produce a stool, rather than not, because there's still a lot of information we can gather from it, like the inflammation markers, the digestion and absorption markers, the commensals, all of the other markers should be fine. So yeah. So just another question here. I've got a lady who is relating to a friend's daughter who is a young 13-year-old girl who has Down syndrome, I believe, and has always had a problem with an overproduction of mucus, specifically what I can gather here, nasal mucus. She's done very well in other areas. Her mother is a herbalist and has helped her with other aspects of her health, but she's now in mainstream secondary school. It can be a problem as her nose is always messy. Can you advise, basically?
Yeah, obviously I'm like, oh, what's going on there? That obviously is a sign that something's still being stimulated in the immune system, and that something is still, causing that nasal airway to react. I'd want to do a proper examination to have a look at the sinuses and make sure that we're not having a sinus infection that's being untreated as well, which can be common. Some of those drainage holes that our sinuses open out into are smaller in Down syndrome. And so it may be something like that needs to be investigated. And as you know, those hollow space infections being really important for the immune cell balance, the balance between the two parts of the immune system. So I would be getting the GP to have a good look at her, making sure you're actually examining her, just to get on my soapbox for 2 seconds. We have an issue in our community, but anything where a patient has a a diagnosis that's so-called lifelong or very persistent is something called diagnostic overshadowing. So every healthcare professional and anyone with a condition needs to be aware of this. It's when you go to see your doctor and they said, that's fine, it's normal for blank Down syndrome. So
Right.
something like this is, make sure that your friends, goes into the GP and to say, no, it isn't normal for someone to have a constantly mucousy running nose, and could you please investigate her as if she didn't have Down syndrome, please? And then lo and behold, the doctor sort of diagnostic skills will begin to, and they will investigate for sinusitis or chronic sinus infection. So there also may be things in that child's environment that they're reacting to immunologically as well, but obviously we look to infection first, but always be on the lookout for diagnostic overshadowing. So yeah, I would say there's still a couple more things to investigate with that young girl. But yeah, there's definitely, you haven't tried everything yet, so keep going.
Yeah. Okay, great. Are you okay to answer just a couple more questions, Liz? Is
Yeah.
that okay?
Yeah.
So I've got another lady here asking, have you treated a Down's patient on diabetic medication with loose bowels?
Yeah. So and just I suppose I'm seeing on my chance here to educate people and to help them have as person first language. So as much as possible, we say a person with Down syndrome, just like you'd say a person with depression, and then that way people in my community won't shout at you and hurt your feelings that you're trying your best to be kind. So yes, autoimmune disease is more common in Down syndrome. There seems to be possibly a core part of the way Down syndrome shows as a cluster of symptoms and syndromes is around that autoimmune issue. And is this diabetes type 1? So as an autoimmune disease there. So if it's type 2, we do have lots of issues around overeating, like psychological issues just generally within the learning disability community in terms of people eating too much and having a poor understanding about healthy eating in the LD community. But in people with Down syndrome, in particular, just thinking about what predisposes them to type 2 diabetes, they have issues with the leptin hormone resistance. So leptin is a hormone that tells you are full. So you and I know when to stop eating. Their body is not as good at hearing that signal. So they can get into a habit of overeating beyond what their body needs. So that can put them at risk of having type 2 diabetes. So it's worth thinking a little bit about that as maybe one of the core underlying contributors to your patient's development of diabetes, if it is type 2. And if it's not type 2, if it's type 1, thinking about autoimmunity, and actually is the patient having other autoimmune conditions. With loose bowels, well, yeah, I have had people contact me with loose bowels, and like we've seen with that our young case, when there's active thyroid hormone destruction, you can run a test at any one time and see hypothyroidism. But when you're having cell destruction in the thyroid, those cells are bursting open. You're releasing thyroid hormone as well. So there's a possibility that you're seeing swinging hyper and hypothyroidism states. So I'd want to have a look at the thyroid hormone as well, investigating that, making sure that that is right. But running a stool test to understand what you're seeing in your patient, because in someone like Elizabeth, she could have gone into a diarrhea state with a dentomy, but it's not always constipation. It just happened to be that's the way it presented with her. So when we talk about whether we treat patients where we find a parasite like blastocystis or dentomoeba, the evidence points us in the direction of treating people who are symptomatic. So now that gives us a lovely wide range of what does symptomatic mean. So we've got anything from loose stool to constipation to bloating so we get a lot of leeway to be able to say, okay, the research points me into actually, I don't need to ignore this. I need to treat it. So I would start to look at like what does this person with Down syndrome actually have going on as well? And yeah, so you've got, you've got two things going on, probably connected, probably maybe similar mechanisms pushing those disease processes forward as well. So yeah, keep digging.
Yeah, yeah. Okay, great. Thank you so much, Liz. Just a couple of very short questions, I think. So just one of them is a question on whether you may do a follow-up GI test to see whether the dientamidine is still there for the markers.
Yes, and Anastasia knows the reason why I've done, one of the reasons why I've done this talk is actually, I'm going to start twisting her arm in a minute to say, instead of paying me for this talk, can you actually please give my patient a repeat test? So yes, I would love to do a repeat test with this client. It's finances that have stopped me being able to do that. I definitely would like to see what's going on and get a repeat stool testing to see if we've got something else going on, or if the flare we've seen in the thyroid result is, actually been going on as the same issue that we saw in the previous stool test, and we need to kind of buckle down and do the same different treatment plan maybe. So yes, the thing which generally, when we think about like longer term support for people with Down syndrome, the kind of conversations that I have with naturopathic doctors like Erica Pearson. So if you have someone with Down syndrome you care about, or loved one, or you're treating, check out Dr. Erica Pearson. She's got a lovely blog on the use of metabolomics in a patient with Down syndrome, and how it's a useful test in our community. She has does a lot of really interesting scientific posts, and has a little library of papers. The kind of approach that we take is that, roughly, once a year, or as your finances dictate it, as long as everything's kind of still ticking along, the metabolomics is a great annual test to see, okay, do we need to point our supplementation in any particular direction? So if we think about my brother, he's 36. So we recently had our follow-up with Dr. Pearson. We ran a metabolomics, and we showed, okay, we can ease off the manganese, but actually we've been going a bit too hard on our B vitamins because homocysteine is now below normal, and that's also an issue. So we've been doing really great. So that's protecting him, right, from dementia and the things which he has higher risk of. But we don't want to go over far too far and give him cardiovascular disease, which normally is low in Down syndrome. So, it's about fine tuning that treatment. And, another thing that we do is with people with Down syndrome, as they get into adulthood, is we do, we think, okay, look, what's the Bredesen protocol doing? What's the kind of things he's taking to, treat dementia? And what can we add in low risk supplements to try and protect our loved ones against developing dementia symptoms? So they have issues where they have a sort of, when you look at their brains post-mortem, adults all have the pathology, the pathology we're thought to associate with Down syndrome, so plaques and tangles. What can we do? What can we add in to decrease that presenting in our patients? So David's taking curcumin and some other supplements like EGCG that have been shown to improve memory and learning. So we add in a few things that we know are low risk, that high potential benefit there, and try and keep our loved ones as healthy as possible for long as possible. That's what we're after for everyone, right? So yeah, that's my kind of approach.
Would you use those botanicals as well for the oxidative damage markers on the metabolomics plus, so things like the A2-HTG and the lipid peroxides?
Yeah, definitely. If I get, I mean, you know what it's like. You gauge each patient, and then you sort of make your plan, and then you cross your fingers. I would definitely love to see a patient like Elizabeth moving into her, middle childhood, being able to add on something like liposomal curcumin to be able to just keep protecting her cells and keep that protecting those cell membranes as much as possible. So, someone's just told me about a really good form of curcumin that tastes really nice in a liposomal form. So I'm going to be trying that out at home and if possible, adding that in. Yeah, it's just getting them in a form that a patient can take. And
Yeah.
I've got, there's a really great, for those of you that treat kids, Bonnie Kaplan did a clinical study where, as a part of that clinical study on micronutrients, she did a whole load of videos about teaching kids to swallow pills. So you can Google that, Bonnie Kaplan, how to get kids to swallow pills. That's on YouTube. So I mean, that's the goal, is actually to get Elizabeth to a point where I'm not fighting with her for these yucky tasting powder multivitamins, because those B vitamins they're funky. That's just, the sulfur in there that just smells. So getting them to a point where they can swallow pills and actually just streamlining the supplementation as much as possible, and trying to help them have as full as life as possible, really. So it's not like carrying around loads of pills. You could go to town, and I know there are people doing intensive supplementation regimes, but again, we don't have the evidence on, just like we don't have evidence for poly pills and multiple different, drug interventions in different conditions. We also don't have the evidence yet for multiple supplementation in Down syndrome. I don't think it's high risk, but I prefer to go a little bit more gentle and not risk overfeeding dysbiosis in the gut, and just being really streamlined as much as possible.
Yeah, that makes sense.
Mm.
Just one more question on a dosage for a specific supplement, the EPA and DHA that you supplemented Elizabeth, right?
Yeah.
How much, do you remember how many milligrams were in each those?
So the one, let me pull open. So the one I went for was the Eskimo one that they sell. Yeah,
Yeah,
that, because it was a flavor that she liked. So
yeah,
that was why I went for that one. And let me just open the plan. I think, yeah, I've got written on here, omega-3, we'll have to find one she'll take in brackets. So I think I went with 5 mils, and I was kind of hoping we could start building up to 10. I, yeah, I'm not, it's being limited by her. I've written upper dose for age range, please. So I went for the high EPA fish oil, basically. I don't go for EPA alone. I want both. And in some of the older clients, they're also taking a separate GLA as well.
yeah,
So I have been able yet to do the finger prick add-on with her. That's my goal, that we can
yeah,
actually see the good results. And that's something which my charity has funded a paper on. Is actually we funded a paper that looked at omega-3 and 6 balance within red blood cells, and we looked at people who supplement in Down syndrome, people who supplement and people that didn't, and it did make its way into those red blood cells. So you are doing something by giving
yeah,
people,
no,
so it did affect.
I see it often on the blood prick finger prick test. You can tell when someone is supplementing, and of course,
Yeah.
when I do practitioners and I ask, is their client supplementing, they will say yes, they are, because the DHA is always a lot higher than what I normally see in someone that isn't supplementing.
Mm.
And the supplementation of GLA is also great, because what we often also see is low levels on that test. So it's great to combine the two for sure.
Mm. And just while I've got it open, if people are curious what my approach is at the moment for her. So I've got her on the omega-3 and upper range for dose for age. And then I think I've kind of had to swap from the powder to, I've gone to a droplet form, but I'm getting mum to train her to swallow capsules. But so I've had to go for the Nutrizorb multivitamin by BioCare. And mum has, since the beginning, been pretty good about getting her on liposomal glutathione. So that has been quite helpful. She's
That's
on
great.
for gut health. Go on.
I was just saying that's great, because
Okay.
liposomes, they do not taste great, and I can imagine it must
No.
be true.
Yeah, exactly. So mom is able to give that, well, I've got it on 1 ml a day, so tiny quantity, just, washed down with a shot of juice or whatever she is
Yeah,
begging for.
yeah.
So she's continuing on Simprove, and I will just say I've seen the unpublished data from the study on Simprove and Down syndrome, and it is extremely promising. And the issue with constipation actually being, so in like say Parkinson's, constipation precedes any motor symptoms by 10 years. So
Wow.
we're also seeing a huge amount of constipation preceding memory issues. So whether the issue with some of these neurological conditions is microbiome, but it's also just like all of the crap, quite literally, in our gut, being able to get through poor gut barrier function, right? So those tight junctions are not so tight anymore. Times it by 10 years, and there's just damage being done to our brain. So we've got a really, really great professor of pharmacology that's just in love with Simprove. He really wants to see this instituted for a lot of conditions. And Simprove, I'm not being sponsored by them, but I really like their ethos. He's an older guy who started it. He's used this in the agriculture and seen a lot of benefits in animals, and wants to bring it the benefits to humans, and is actually funding a lot of these studies himself. So L-glutamine as well, I've asked them to continue that. And there's a couple compounds that have shown benefit in autoimmune thyroiditis in adults. So I've started on some low dose of ashwagandha, myo-inositol, and some selenium. So the myo-inositol together with selenium has shown benefit in clinical trials in calming down autoimmune, and has ashwagandha as well. So, all of those things have been used in children for other reasons. So I felt it was safe to trial her on some low dose of some of those. And hopefully we can see some of those autoimmune markers calming down. But, I never come at it from just one angle. I try and kind of go to the multi-different angle, try and tackle it from different angles. Yeah. So that's the current supplement plan. Mum's got to get her head round, and I hope she will, because she's stuck with it so far. So
Yeah, no, that's great. Listen, it's been so interesting to talk through all of these points. Thank you so much, Liz, for your time. I really appreciate it. We really appreciate it. Just a reminder for everyone, this has been recorded, so we will send it to you probably later on today. I think that's about it, unless you want to say or add anything else, Liz.
no, thank you everybody for listening, and I've seen that you all stayed on and you're interested, so I hope it has been an interesting conversation, and just encourage you to consider taking these patients on. You can do so much of the preliminary work in your clinic, and reach out to other professionals. I've created a group for people who are functional medicine minded and treat people with Down syndrome on Facebook. I think it's called Functional Medicine and Down Syndrome. So if you are a practitioner, please request to join, and we can create a bit of a peer network where we talk about what we see on the testings, like stool testing and metabolomics, and reflect on the importance in your client.
That's great. What I'll do is I'll get that link from you and send it in the follow-up email later on today, in case anyone wants to have a look at that. Yeah, great. Thank you so much, Liz. I'm sure we will speak soon, and thanks everyone for your time today. Have a lovely rest of the day.